This is Host Jockeys Unite, the only episodic podcast that strives to not only educate and entertain those in emergency services, but to give an inside peek inside the fire and EMS services to the general public. We are here to leave a legacy for future generations. And now, here are your hosts, Chris Edwards and Jay Gallagher. Hello and welcome to Host Jockeys Unite. I'm your host, Chris Edwards, and this is my co-host, Jay Gallagher.
Hey everybody, we 10-8.
And today we have a special guest with us, Will Adams.
How's it going, everybody?
Sounds good. In this episode, we're going to be discussing a topic that is causing a nationwide crisis, the opioid overdose epidemic. We'll talk about what many consider to be a wonder drug, Narcan. We will also explore what Narcan is, what it does, and when it is appropriate to administer it. So sit back, relax, and enjoy the show. As mentioned before, my name is Chris Edwards, and I'm your host. I began my career in the fire service about 6 years ago as a volunteer firefighter and became a paid firefighter about a year or so ago, at which time I got my EMS certification, or EMT certification. Jay, tell us a little bit about your history.
I'm a retired firefighter, paramedic. I retired out as captain. Got about 30 years in on the job, both on the paid side and volunteer. And it was a fun ride.
And Will, how about yourself?
Do what?
I said, Will, how about yourself?
I've been involved in EMS in some way, shape, or form now for a little less than 10 years. I've been in a volunteer department for over about 5.5 years now total. Went paid EMS as an EMT a little over 4.5 years ago. Now I'm a paramedic. I've been a paramedic for about a year and a half, and I've been a volunteer fireman for the past 3.5 years.
Right, and actually, emergency services is what all brought the three of us together, actually, with our short time we had in our volunteer group that we were trying to create REACT. So, welcome to the Ask the Firefighter section. This is where we answer questions that you, the listener, send to us. Today's questions is, are volunteer firefighters real firefighters? Jay, can you explain this question?
Sure. And the answer to the question is yes. They are every bit real firefighters. They are equally trained as the career firefighters. They have to have the same certifications. The only difference between the two is when a career firefighter goes to work, he reports to the fire station. When a volunteer reports to work, he reports to the grocery store where he's a manager at, the job site where he works construction, or the garage where he's a mechanic. When the pager goes off, they switch gears and they're just as much professional as a career firefighter. The only difference between the two is the way the training is set up in the area where their department is located at. Either way, state requirements 36 hours of training per year for a firefighter.
Right. And
you can get it. Go ahead.
I was saying, yeah, and if you look at it, let's say you have the guy who's a volunteer firefighter who's works a construction job. A career firefighter knows what the building codes are supposed to be, but the guy who actually builds the buildings knows how the buildings are actually technically being built or realistically being built versus how they're supposed to be built.
Exactly. That's good. The firefighters that are volunteer, they have the opportunities for training to go to weekend school, go to other training, their resume, so to speak. And the career firefighters, every shift, they spend a certain amount of time during the shift training. They either do it in the classroom at the station or go to the training grounds and, for instance, burn a car or run rope drills or, just different things for different shifts. But, yes, volunteers are real.
Okay, Jay. Well, thank you for answering the question. So never let anyone say volunteers are not real firefighters. If you have a question about the fire or EMS service that you would like to answer on the show, or would like to learn more about how to become a volunteer firefighter, please email us at firefighter274@outlook.com.
Ladies and gentlemen, the topic of this episode this evening is it can be considered highly sensitive. Opioids are highly addictive, and the opioid abuse has really become a national crisis in the United States. Today, we're lucky enough to have a guest with us, my and Chris's very good friend, Will Adams, who is a paramedic, sees this on a daily basis.
An opioid overdose happens when a person takes too much of an opioid or a combination of opioids and other drugs at a level that is toxic to the body. The National Institute on Drug Abuse reports that more than 2 million Americans abuse opioids and that more than 90 Americans die of an opioid overdose every day on average. Some of the signs and symptoms of an opioid overdose are slow, shallow breathing or stop breathing, extreme sleepiness, inability to talk, blue skin color, cyanosis, and dark-colored lips, snoring or gurgling sounds, unconsciousness, cold and clammy skin, pinpoint or restricted pupils. As a bystander, how do you respond to an overdose, you might ask? Well, once you identify the overdose, call 911 immediately. Try to wake the victim up. Call or yell their name. If they don't respond to your voice, rub the middle of their chest with your knuckles. Start rescue breaths and CPR if the victim is not breathing or breathing slowly and is pulseless. Follow the instructions of the 911 dispatcher. Then administer Narcan if available, following the manufacturer's directions. Try to note the time given that the dose was given. Put the victim into the recovery position once the person is breathing again and put them on their side with their top leg and arm crossed over the body to prevent choking. Remain near the victim and keep an eye on the person until emergency help arrives. Here's a pro tip. Don't place the victim in water or get them wet or put ice on them trying to sober them up. That's just a waste of valuable time that could be used to save a life. There is no way medically speaking that this will help an overdose victim and makes the EMS crew's job even more difficult.
Hey, I got a few questions because Narcan actually came out after I retired out, and I'm kind of green to it. So, Will, can you tell me exactly what is Narcan?
Well, Narcan is a medication that's brand name is Narcan. It's an FDA-approved drug called Naloxone. Generally, we use it in the field. It's used for it kind of helps to restore the respirations and make someone breathe, basically, of any time they have taken too many opioids or there's a suspected opioid overdose. The one thing I will say is that naloxone was patented back in 1961 and approved for opioid overdose use in the United States in 1971. However, as this has gotten from considering that EMS generally was just starting to get into its baby steps of its career in the United States in the early 70s, as we all know through the TV show Emergency, we now have kind of had a delay in getting that medication out into the emergency medicine field for first responders to be able to use, as well as law enforcement and bystanders themselves.
Gotcha. And Chris, how exactly does Narcan work to reverse opioid effects?
Well, the scientific definition is that naloxone or Narcan is an opioid antagonist. What that means is that it works by binding with opioid receptors in the brain to rapidly reverse the effects of overdose. This process happens on a molecular level. These receptors are like cups, and the opioid molecule is like a ball shape, and it will seed itself into the cup and bind with the receptor. This is what causes the effect of being high and eventually the overdose symptoms. The Narcan molecules will instead seed itself into the receptor cup and bind to the receptor to block any further opioid binding and absorption, thus effectively reversing the opioid effects.
Okay. Interesting. Will, how exactly is Narcan administered?
Well, Narcan can be administered in a few different ways. Generally, the most common way that you'll see it given is intranasally or through someone's nose. Um, Generally, what that means is you have a syringe with a particular device on it that you actually insert it into someone's nose. You spray it in there, it forms mist, and it's absorbed through the mucous membranes in someone's nose. Another way that we can give it is for some of the people that hold higher level certifications in the EMS field, like advanced EMTs or paramedics. We can give it through IVs. So we start IV, push a smaller dosage of it through an IV, as well as we have what we call intraosseous, where we actually put a needle into someone's bone directly. We can do it that way. There is some stuff that you can get over the counter as well as through prescription that you can go into someone's arm or someone's leg, just like you would with an EpiPen or just a regular shot. Basically, like getting your flu shot for an emergency use. And there's also a way that we can give it through a ET tube, which is basically where you're already intubated. So you have a tube down your throat, and we can push a dose of Narcan or Naloxone through that endotracheal tube, and it'll absorb in through your lungs, and it gets into your bloodstream almost as fast as it would through an IV.
Okay, so it's kind of like giving it a little bit of extra push going through the ET tube, I guess.
Yeah.
You did say it was quicker or just as quick?
It's almost as quick because you're still getting into the bloodstream a lot quicker than you are being absorbed through the mucous membrane in the nose.
Okay, I kind of misunderstood that part. I'm sorry. All right, Chris. What is the dosage for Narcan administration?
Sure. So the current dose for Narcan in North and South Carolina is adult is 0.4 milligrams to 2 milligrams intranasal, or pediatric, which is 0.1 milligram per kilogram intranasal to a maximum dose of 2 milligrams. Where I work, my current protocol states that administer Narcan 2 milligrams or 2 milligrams intranasal via a MAD device, and then titrate to the patient's respirations, not given to regain consciousness. And what that means, basically in plain English, is to administer 2 milligrams of Narcan in the nostril using a MAD device. A MAD device, or mucosal atomization device, which is what Will was talking about earlier, is a cone-shaped device that fits on the tip of a syringe. When liquid passes through it, the liquid is then transformed into a small mist form, and then we only give enough Narcan to get the patients to start breathing on their own, but not wake them up. And I'm going to say this jokingly, but it's true. If you've ever been around an overdose patient that wakes up, it's a quick and startling response. It's a shock to their system, suddenly going from basically dead to alive. Often they wake up pissed off and start swinging at you because you just ended their $500 high. Many agencies, especially many agencies, especially law enforcement and fire departments, will carry pre-dosed Narcan kits that resemble nasal spray. These kits administer a 4 milligram, a whole 4 milligrams of the drug. With these kits, it's a one-shot deal, 4 milligrams or nothing, and there's no way to regulate the flow of the medication. So it's basically like a Primatene mist or a nasal spray. You just stick it in their nose and squeeze it, and they get 4 milligrams off the bat.
Got it.
And Will, what's the protocols about where you work?
Well, being I'm on 3 different agencies, the protocols that we have, they vary from agency to agency. With the volunteer agency I volunteer with in the EMS side of it, we are in that 4 milligram dose of Narcan where it's all or nothing. Generally, the reason why it's that 4 milligram dose of all or nothing is between us, sheriff's department, police departments that we have throughout our county, other first responders throughout the county. The reasoning why is because that is considered a high stress call. Between you have family members that are freaking out, you have friends that are freaking out on scene. So you start piling all that stress onto first responders or law enforcement officers. It kind of builds up. You start shaking. You don't want to freak out, draw up the wrong dose. You don't want to stab yourself with a needle. So it's that all or nothing dose because it's one self-contained apparatus. You just go straight into the nose and that's it. Makes it a whole lot easier to deal with, both to give it to a patient as well as to not have to worry about a cleanup or any incidental harm that you have to place yourself in. The dosage that we give for my paid position that I have is similar to Chris's. We do have an adult dose of Narcan being 0.4 milligrams to 2 milligrams intranasally or intramuscularly, or through an IV, or, like I said before, through the intraosseous needle that goes into the bone or the ET tubes. Generally, if we're doing it intramuscularly or intranasally, we're going to give anywhere from 1 milligram to 2 milligrams at a time. Same with the IO. We don't generally see the intramuscular route or the endotracheal tube route as much where I work at because we're so close to the hospital that a lot of times we can give that little bit of Narcan to start regulating the person's body and kind of get going in that right direction. Generally with IVs, I start at the bottom with 0.4 milligrams because you're going in through the bloodstream. It's getting in the bloodstream a whole lot quicker than going through the nose. We generally get a much better response through the IV use.
Gotcha. Now, I'm just assuming here when you're talking about the MAD device that it's something similar to a nebulizer, correct?
It's fairly similar. Whereas the nebulizer, you're kind of it's turning that liquid into a mist through oxygenation. I'm not 100% sure how the MAD device works as much, but I do know that it does still create that mist without having to use oxygen behind it.
Yeah, it kind of reminds me of a bubbler stone that you would use in a fish tank. It looks like a bubbler stone, to be honest with you. Like if you ever seen a bubbler stone that they put in an aquarium that it's like a rock and then air's forced through it and it just creates air bubbles. That's kind of what it reminds me of, but it just uses what air is actually in the syringe instead of like an oxygen supply.
Yeah.
Gotcha.
Chris,
Okay.
I do have a question for you.
Yeah, go ahead.
Being that you're in a different agency, a little bit farther away than where I am, do you guys have a max dose on your adult dose of Narcan?
On the fire side, the county that I work on the fire side has limited it to 4 milligrams.
Mm-hmm.
So on the first responder side, so if law enforcement shows up and gives them 4, then it's no more until EMS gets there. As far as on the EMS side, in the other county where I work, in 2 different counties, in the other county where I work, it's I'm not 100% sure off the top of my head, but I'm pretty sure it's more than 4 milligrams. But like I said, our protocols really don't want you to wake them up. It's just enough so they can start breathing again.
Okay. Well, the only reason why I ask is because we don't have a max dose for pediatrics or adults. Generally, we're told that, like yours is, we're giving Narcan to help restore a patient's respirations, to help get them to breathe again. If they wake up, that's great, but we're not looking to give Narcan just to regain the consciousness. I mean, we even have it in our protocols that we can be giving up to 10 milligrams at a time without having any response from the patient, and that's perfectly expected and normal.
In case y'all are wondering, I'm writing down notes of what y'all are saying just from my own personal knowledge, future reference type thing.
Gotcha.
Not that I'm planning on ODing on opioids anytime soon, but you never know, Walmart, something might happen, and you know.
True.
Okay, Will. Um, just as a general rule of thumb, or how long does a dose of Narcan usually last?
Depending on the amount that you receive, generally the half life of the medication can last anywhere from 30 to 90 minutes. So it generally, depending on the opioid that they've taken, you can generally expect to see that the Narcan can start to wear off prior to the effects of whatever opioid they have in their system wearing off. So I mean, you could have Narcan that wears off, and the opioid they still technically overdose again because they still have that overdose amount in their system when comparing to the amount of Narcan they've received.
That was going to be my next question. Um, so it's usually 30 to 90 minutes, depending on what they've OD'd on, correct?
Well, not necessarily what they've OD'd on, but the amount that they have taken.
Okay.
Yeah, it's the amount of it's the half life of the opioid that they've taken versus how long Narcan lasts. So Narcan generally lasts from 30 to 90 minutes, but a lot of times the opioid effects will last longer. So when that Narcan starts wearing off, they're going to overdose again, and that's basically all it is because the Narcan wears off faster than the opioid does.
Okay, now just for S&Gs, you may have touched. I believe you might have touched on it a little bit previously. But what happens if you give too much Narcan to a patient or to someone who doesn't need it?
Well, it's virtually impossible to overdose on Narcan or overdose someone with Narcan. The worst thing that will happen is they will fully wake up, and it happens regularly on overdose calls due to breakdown in communication between agencies. For example, a law enforcement officer will arrive on scene and administer a 4 milligram dose of Narcan in the quick kit. Then fire department might show up a few minutes later, and not having been told that the patient has Narcan on board, they'll administer another 4 milligram dose. Well, that's 8 milligrams on board, and then by the time the EMS gets on scene, that's 4 times more than the maximum dose per protocol. At this point, the patient is already awake or about to wake up, mad as hell. Physically, there is no harm to the body with too much Narcan on board. If it is given to someone that doesn't need it, say they were just sleeping or has overdosed on something other than an opioid, or is passed out from intoxication, at worst it might make them uncomfortable. And then the only exceptions would be for an individual who has an allergic reaction to Narcan or a woman who is pregnant or nursing.
Okay. Now, Will, does Narcan work for alcohol or non-opioid drug overdose?
No, generally the way Narcan is, it's designed to only work to reverse opiate or opioid-based medications. So you'll see it more. It'll work specifically with You'll see some like prescription medications. Like occasionally you get people that have fentanyl patches. You have morphine. Um, those medications are generally the medications that you look at. You'll get Narcan with. For street recreational drugs, as some people will view to see them as stuff like heroin. You get people that are doing, like what they get to be cocaine or crack or even marijuana that is laced with fentanyl. You can get people do get fentanyl on the street. It does start from a prescription drug, but it does end up on the street. And generally, you're not looking to reverse the effects of what that cocaine does or what that marijuana does to the body. It's only going to work for those opioids or opiate-based medications that are in whatever drug it is that you've taken. Narcan itself will not harm anybody that's overdosed on alcohol or any of those non-opioid or opioid-based medications. which is why you see it that it's so readily available for bystanders to give law enforcement officers with a short, brief stint on how that medication works, and even first responders that don't do EMS as their primary care. That's why we stress the importance of calling 911 immediately if you suspect that there's any type of overdose, because you want to make sure that you have that help on the way to help get that further care in case that Narcan is not what's needed for that particular situation.
Gotcha. Okay. Now, Chris, is naloxone just a crutch, so to speak, or that allows you to continue to take opioids and overdose on them?
Okay, so I'm going to read this word for word what I found online, but I don't necessarily agree with what I'm getting ready to read. But it says research studies have investigated this as a common concern and found that making naloxone available does not encourage people to use opiates more. The goal of distributing naloxone and educating people about how to prevent, recognize, and intervene in overdoses is to prevent deaths. I agree with that part. However, it also says encouraging those who have experienced an overdose to enter into treatment is an important component of an overdose prevention plan. Now, my opinion, after being in the field and experiencing multiple overdoses, is that I tend to disagree with this statement. I've been to calls multiple times where an overdose patient is the exact same person that we were called to out as little as 6 hours earlier and administered Narcan, CPR, all the pertinent life-saving measures. The patient wakes up and refuses transport to the hospital. 6 hours later, we get another call to the same address for the same person in the same situation. Wash, rinse, repeat. Call me negative, and I would never, ever withhold it from anyone, but I see it as a crutch in a lot of cases, and I don't think I would feel the same way if patients would accept transport to the hospital to get them checked out and more needed care. Will, how do you feel about this? You've been at this a lot longer than I have, and on the EMS side, much longer. What are your thoughts on Narcan being a crutch?
I can kind of see it being a crutch for some people. Narcan is given to patients both as a precautionary thing as well as something that's needed in an emergency situation, like I deal with a lot more. People that get prescribed these opioid-based painkillers, like your morphine, your fentanyl, stuff like that, you get fentanyl patches. They get given Narcan because sometimes it does happen. You accidentally take a bit too much. Sometimes people won't have that respiratory distress that we're looking for, and they'll want to use that Narcan right then and there. By all means, absolutely do that. Just know that doing that, you're going to end up having issues with that pain that you're taking that medication for to begin with.
Right, and I've actually seen it quite a bit on the fire side with elderly people who have overdosed on, their medications they get from the doctor. And that I can see it as a viable reason to be given Narcan, but not the 18-year-old that overdoses because they were having a party and then we get called out to the same address 6 hours later because they refused treatment to go to the hospital.
Yeah, and that's the thing, is that's where it becomes, it's an educational thing, because when you have that patient sign that refusal form, you're basically allowing them to sign their life away with the understanding that regardless of what happens after you leave there, that you can't be held liable for anything that happens to that particular person. And you're explaining to them that once you walk out that door, whatever happens in their life is completely on them at that point. That they could fall back into those same symptoms again, where they start to get the shallow breathing and eventually stop breathing. And you're explaining to them basically that you could die again. And the biggest constraint that we have is that people are more scared because the first thing that happens when we get paged out to an overdose call
Law
is
enforcement shows up.
right, law enforcement shows up. So they see someone with a badge and a gun, and they expect that they're going to be in trouble for what happens on with that particular thing.
Yeah.
North Carolina itself has laws to protect people from prosecution when they call 911 for an overdose. Both the patient, the bystanders that are there, whether it's friends, family, it doesn't matter what the circumstances are. I mean, granted, North Carolina does have a couple requirements with that law. One being that you're acting in good faith for the person who's overdosed, that you're able to provide your name to the 911 dispatcher or law enforcement officer that shows up to that call. You're not seeking medical assistance as a result of being served a arrest warrant or search warrant or other lawful search, or you have like it's not being used against you for evidence for prosecution for of offenses listed prior to that. So basically, if you have just a little bit of heroin or whatever, you overdose, you have law enforcement show up, they may take your stuff from you, but you're not going to get in trouble for it.
Well,
'Cause
yeah.
At the end of the day, regardless of who shows up to that call, whether it's that law enforcement officer, that firefighter, that paramedic, EMT, whoever, they all want to see what's best for that patient. Whether it's you go to the hospital with us, you go to the hospital with your family, whatever makes you more comfortable, as long as we know that you understand what this medication is going to do to you that we just gave you and how it's going to react with your body over the next 45 minutes to an hour to hour and a half. We want to make sure that we're covering all of our bases. I mean, it's at the end of the day, I'm not going to withhold Narcan from someone, but knowing how that medication is going to work and what it's reversing and how the stuff that's been put in that person's system is already acting, I'm not going to delay care, but I'm going to try and get you to a doctor a lot quicker than other people that I work with will. And it's not to say that they're not doing everything that they can do for that patient. It's a lot easier because of the fact there's family, there's friends, there's other people there. It's a whole lot easier for me to control my environment and provide a safe environment for both myself, my partner, patient, and everyone else involved. So just get that patient to the back of the truck and get going down the road, especially consider that most of the time I'm 5 to 10 minutes away from a hospital where some people may find themselves to be 45 minutes to 2 or 3 hours away from
Yeah, you're lucky on that aspect. A lot of times we have to go 45 minutes, 30 minutes, depending on where we are on a call. And you're right. The only reason that law enforcement even shows up with these calls is more or less to protect the first responders and the EMTs, firefighters, and whatnot who can't protect themselves. Because sometimes these patients do wake up violent, and you just don't know what you're getting into. But to me, it's just really disheartening and heartbreaking to see this 17-year-old wake up, or 18-year-old, 19-year-old wake up and be like, no, I'm not going to go to the hospital because I'm fine. Because they're scared they're going to get arrested for possession of whatever. And they're not. It's just, if they were selling it, yeah, that's one thing. But, you really don't get in trouble for possession for the most part.
Yeah, I mean, there's so many different things that happen in that particular instance, and no one wants to admit that they've taken it. And that's the biggest problem that we run into, is that people don't want to necessarily be honest with us about it. Like, you have all these signs and symptoms that tell me that this is what happened. You have that shallow breathing. You are extremely sleepy. You don't want to talk to me. Sometimes you get that blue color. The big thing that we notice a lot is that snoring or gurgling sounds. And generally that's the one thing we're looking for when we walk into a room and see a patient, is that if you're snoring or gurgling, we know immediately that there's some sort of airway compromise. And then while we're doing that, we're also looking at someone's pupils, looking at their eyes. If they're pinpoint and constricted, they're not very reactive to light because of the opioids in their system. That's generally the biggest signs that we're going to look at for giving Narcan. And then when people wake up, it's, no, man, I didn't take nothing. I just had a couple of drinks. That's it.
Yeah.
I don't care that you had anything. I don't care because it's your choice. It's your life. It's your body, whatever. You can do whatever you want. The only thing that I ask is just be honest with us, because at the end of the day, we're there to make sure that you can walk away from this incident, and hopefully I have to see you passing down the road, going through the drive-thru at McDonald's or something like that.
Well, not only that, but I've noticed they refuse, literally, absolutely refuse to tell us what they take. They might say, yeah, I took drugs, but they refuse to tell us what they take, what they've taken. And that's important because, I mean, it affects how they're cared for. But not only that, it affects our safety as first responders, especially with fentanyl. If it's, powdered form, it takes very, very little, like micrograms of fentanyl to become basically not intoxicated, but become contaminated with fentanyl. And as a responder, that's our lives on the line too.
Now, I want to circle back for just a minute. I got a question I want to ask.
Okay.
When y'all were talking about them signing the patient refusal form.
Yeah.
Now, it may have changed. Again, I'm a fire and EMS dinosaur. But in order for someone to be able to sign a patient refusal, they had to be conscious, alert, oriented to the situation. Correct?
Correct.
Okay, now, does Narcan, once it's administered and they come to, does that wonder drug, we'll call it, sober them up to where they meet that criteria that quick?
Yes.
It does?
Yes.
It can. There's been some instances where we've had to sit on scene with patients a little bit longer than we want to, because even after you've given Narcan, they're still out of it. So, I mean, it's not that fight or flight response that everyone has kicks in. It's just that they don't recognize the environment that they're in. So we have to sit there a little bit longer because we don't want to create that. We don't want to agitate that fight or flight system that everyone has. So, I mean, we'll sit there a little bit longer and we'll wait because it's safer for everybody. And then generally in that time frame, more Narcans get into the system and starting to reverse everything. They start to be a little bit more alert. And I tell people all the time, if you can answer these questions for me, then we have no choice, but I have to take you to the hospital. Because
right.
I can't leave you in that environment where I don't feel comfortable with you being
right.
left alone.
Just in my experience, generally everyone I've ever ran, they've come to the point where they meet the criteria for being able to refuse.
Right. So those four things that we're looking for is we want to make sure that person's alert to who they are, the time that we have going on, where they're at, and the event of what's happened to why we're out there. So, I mean, you get those four things covered, then, we've kind of met the criteria that we need. And a lot of us that work in this field generally try to take it a little bit further. We're not just going just for that, well, I know who I am, I know where I'm at, I know what day of the week it is, and I know why you're here, or what you tell me is why you're here. But some of us will go a little bit further and say, well, how many quarters make $1? Is Mickey Mouse a cat or a dog?
Yeah.
Stuff like that. Because then it's that you're agitating that person's thinking process to get them to think about what's going on as well.
And probably the stupidest question lately that everybody asks is, who's the president? I hate asking that question. It's like the most ridiculous question ever to ask.
But I mean, that question works really well though because it's either will sit there and say the president's President Biden, or they'll sit there and go, "Man, I don't like that guy."
Yeah.
It's you're gonna get a response from it, and if you can get a response that's detailed like that, like, "Man, I don't like that guy," and they can tell you who it is, then it lets you know that that person is definitely alert to the situation that's going on.
Right.
Okay, moving on a little bit down the line here. Uh, Will, do you have a war story? It could be funny or it could be something serious that happened on a overdose call that you ran.
I've got a couple stories. One in particular that really sticks out to me is that we've ran numerous overdoses in town. It's known that there is a drug problem pretty much across the world nowadays. But there was one time we had a patient. He overdosed. Um, the way that I was working with the partner I had that particular night worked a little bit more gung ho. We like to be in there and get into things a little bit deeper than we probably should. And we never violated any policies by doing or procedures or anything like that by doing so. But we got there. Basically, we got a short rundown from bystanders that were there, threw the patient on the stretcher, and I grabbed my BVM, which are bag valve mask, sorry, um, and started ventilating the patient, basically breathing for this patient as we're walking out to the ambulance. Um, PD showed up as we were walking out the door, so we get inside the ambulance. My partner takes over for me, ventilating this patient, breathing for this patient. I get an IV started, and I give my zero point 0.4 milligrams of IV Narcan. Get going down the road, and I'm like, okay, this patient's starting to breathe on their own. Their blood pressure's good, their heart rate's good, their oxygen saturation's returning back to that level that we want it to be at. I no longer have to breathe for this patient. I call the hospital, I was like, hey, we're on the way to your facility. I've got this, just going to throw out a random age here, 28-year-old male. Chief complaint today is going to be a suspected overdose, an unknown cause for the overdose. And you tell them the signs and symptoms you have. Patients got snoring respirations, pinpoint pupils, and you sit there and you go down the list of all the symptoms you have. You give them the vital signs, and generally when we go to the hospital, we tell them we're either en route to your facility, routine traffic, or emergency traffic. And my patient still, he's out of it, didn't wake up, get to the hospital, walk into the hospital. We took this patient in routine traffic, and we walk into the hospital, get him moved over to the stretcher, and the nurses are all looking at me like, you brought this in routine traffic. I'm like, absolutely. They're like, why did you bring this in routine traffic? And it wasn't that they were upset with the situation, it's more them trying to understand this is something they're going to consider an emergency. They, the first thing most of the time the hospitals do when they get into in that situation is they're reaching for Narcan and they're pushing Narcan. They're giving it a lot quicker than what we do in the field. And it's because they're in that controlled environment. They have doctors there. I don't have a doctor in the back of my truck. I have a written set of protocols that says this is how I have to act, basically in the best interest of my patient, given this particular set of criteria. And I explained to him, I was like, my patient, other than the fact that this patient is not responding to me, this patient is stable based on his vital signs. He's breathing on his own, and at this point, he's just asleep. And they absolutely have lost it. And they're like, this is not right. You shouldn't do this, blah, blah, blah. And I'm like, but this was the best interest for my patient. Get thrown around the back of the truck. I can't take care of my patient. So me coming to the hospital routine traffic, not causing a display of disruption for someone in the back of my truck, I have gotten my patient to the hospital safely, as well as providing the best care that I possibly can for this patient to allow them to get to that higher level of care that they need to get to. And it turned out after the fact that this particular person had just been discharged from a rehabilitation facility and was now trying to had a bad day, end up going back to it, and is now, from my understanding, returned to that life of clean living without the need of a substance to help him cope with things going on in his life.
Very cool. Very cool.
Sometimes I think that the ER nurses, and God love them because they put up with a bunch of crap in the ER. We all know that, but sometimes it's like like when we bring in a patient routine traffic, like in your situation, and they don't, they think we should, have bought them emergency traffic. It's like they don't realize that we have a drug box there. We have protocols there in case that patient starts to crash. We got it covered, and we can always bump up our transport from routine to emergency traffic. And it's it's not like we're going to let the patient lay there in the back of the truck and die. It's sometimes they just don't seem to catch that. To me, I mean, I've had things like that happen before. It wasn't actually a suspected overdose, but we were questioning why we come routine versus emergency traffic, and it's kind of the same situation you were in.
I think a lot of times that particular thing, I think it boils down to at the end of the day that nurses have to be given orders to do their stuff. There's a lot of times that they know this is what they're going to do, but without that order being given by a doctor, they can't a lot of times act the way that they know they're going to have to act for that patient's best interest. Where us being in the field, whether it be firefighters, EMS, we have a written set of standing orders so we can function at that moment without having to ask for permission to do stuff. And I think that's the difference, is that a lot of times people in the hospital don't understand that we can do stuff without having to have permission to do it 99% of the time.
And, well, I got kind of a funny war story. Back when I got into the EMS side of it, we didn't have the opioid problem. It was cocaine, heroin, all the fun stuff of the early '90s. And it was 4th of July weekend, and this was back when I was living down on the coast. We get dispatched to the KFC, Kentucky Fried Chicken, for an unresponsive patient. Okay. So we go diddy bopping down there in our big red fire truck, pull in, and we go in, and unresponsive patient, I'm thinking somebody's either going to be laid out over the table, unconscious, or out in the middle of the floor. No. This guy was sitting in the corner. He was conscious. He was alert, but he wasn't oriented to where he needed to be. Basically, what I mean is he was staring straight ahead. He never moved his head one bit when we first got there. We tried to move his arm so we could get a blood pressure. He wouldn't move. I mean, he would tense his muscles up and he wouldn't move. And the best of my recollection, he didn't even blink. Okay? which was, totally strange to me. Um, I get up next to him, and I won't try to get his blood pressure again. And I look at him, I said, "Sir, I need to take your blood pressure. So I'm just going to move your arm just a little bit." He turned his head then and looked at me and said, and I quote, "I'll kill Saddam Hussein." And buddy, it was on from there on. It was like riding a bucking horse trying to get him to. He basically destroyed the dining room of KFC. And before it was over with, it took me and two other guys on my engine, two EMS, and four PD and KFC manager to get this guy down onto the ground. And it, like I said, it was like we were riding a bucking bull trying to get him down on the ground. It'd sling us. All right, Will, you remember the night we went to that breathing difficulty and the woman pushed you over in the ditch and me up on top of the ambulance?
Yeah.
Kind of like that. It was an interesting 10 or 15 minutes. But the paramedic finally got some, I guess he popped him with Valium. I don't know. I was busy trying to keep alive, really. Popped him with something, and he chilled right on out and laid down on the floor. And then we were able to do what we had to do and package him and got him out. And when we got back to the station, we had to. I know I had to change my shirt because he ripped it half off. And I'm serious. It was. I don't know if he was having a flashback from Desert Storm, or which is kind of what I've been, going on the assumption of ever since it happened. Because unfortunately, we never found out what happened to the guy. But he just slow turned the head and I'll kill Saddam Hussein, and it was on. Chris, how about you? You got a funny or not so funny war story?
Yeah, I've got a couple of stories actually I'm going to share. And the first one is definitely not PG-13, but it was about the first time my first time ever seeing Narcan in action. So we're on a call, and this was on the fire department. I was on a call, showed up, EMS was already there, and they asked me to bag the patient. So, as we're taught, I'm at the head of the patient on my knees, ventilating the patient with a BVM. And I'm not aware that they've already given Narcan. So, I'm bagging this patient every 6 seconds like we're supposed to. And all of a sudden, this girl wakes up, sits straight up. The BVM goes flying across the room. I fall on my ass and go, "Son of a bitch!" The whole time this is happening, the paramedics are over there laughing at me because I'm not expecting this. This girl to sit up straight from being dead to wide awake. And I had never seen anybody on Narcan before, and this BVM goes flying across the room. The paramedics are over there laughing at me, and I'm sitting here on my ass in water because, of course, the girl was wet. But it scared the shit out of me, I'll be honest with you. And then the second story, it's not funny more so than interesting observation on my part, and this happened actually last night or the night before. We responded to a 17-year-old heart attack, and we go there mainly because we had a Lucas device and they needed a Lucas device. Well, we get there, paramedics are already on scene. I mean, they pull up literally right before us, so we get there, follow them in, and this girl is laying on the floor in the living room, dead. So I proceed to get the Lucas device out and get it all put together, get it turned on, get it on the girl. My partner is getting ready to drop an airway, and as soon as he starts to put the eye gel in, he notices there's some movement in her in her jaw, and she's starting to get a gag reflex. So like, cool. I never actually turned the Lucas on because they wanted to do a rhythm check. Well, I was actually getting ready to turn it on, and they're like, "No, hold on a second. Let's do a rhythm check." So they get a pulse, and the thing that I found interesting is I've never seen a person come out of it without any Narcan. She started to breathe a little bit on her own, and then once we administered Narcan, she wakes up fully. And of course, at that point, it's a 17-year-old girl, doesn't have a top on because we're doing CPR, and it's a shit show from there on because like she's freaking out because she's dead, and then all of a sudden she wakes up. But that was the first time I've ever been on a call where we've actually gotten ROSC on the scene, so which is return of spontaneous circulation. But I just found it interesting that she woke up without any Narcan, and then they gave her a little bit more, and she woke up fully. And I had never seen that before, so that was my second story. It was just a little bit of an interesting side story. And as we've seen on our show today, the opioid overdose is becoming an epidemic throughout the whole United States and pretty much throughout the whole world. And I feel like the only way it's going to change is through education and things like that. Will, what are your final thoughts?
At the end of the day, if you're not sure if someone that you know and love is in the midst of having some sort of medical emergency, whether it be an overdose, heart attack, stroke, anything, don't hesitate to call 911. Our job is to take care of you and your family, your loved ones, whoever, regardless of the situation. And it's always going to be the best outcome. We'd rather do paperwork for a little transport to the hospital than have to sit there and tell you or any of your family members that we've done everything we can, but there's nothing that we can do that's going to be beneficial.
Jay?
Well, like I said before, Narcan had come out after I retired, and the opioid overdose epidemic, if you want to say that, as wasn't as prevalent then. We had other things to worry about as far as overdoses. But either way, it's a sickness. Addiction is a disease, and the sooner people wake up and realize this is a disease that can be treated before it gets out of hand, the better off everyone's going to be. Now, on a personal note, for all of our listeners out there, I've watched Chris and I've watched Will from the first day they signed the application to join the fire department and get into EMS to present. And they have come a long way in a short time. And I just want everybody out there to know just how proud I am of them. Sometimes they pick on me and tell me I'm living vicariously through them, and it may be so, but that don't stop how proud I am of them. And I hope that they continue and get out of their careers as much as I did.
Okay, and so don't forget to tune into our next episode where we will discuss the ever-increasing problem of violence against first responders. And on that note, I think Jay wanted to drop a little something in reference to next week's topic.
Yeah, we had here in Moore County, here in North Carolina, I'm not going to say a whole lot on it right now, but two power substations was destroyed, and Moore County is without power. And the last report I heard was Thursday of getting it back, and this happened on Sunday morning. For right now, I want to send my thoughts and prayers out to everybody in Moore County. Keep your heads up, stay strong. It won't last forever.
And don't forget to subscribe to the show on your favorite podcast platform and leave us a review. We're listed on all the major services. We'll see you next time. And a special thank you goes out to Will Adams, today's guest. The show would not have been possible without his help. Hope you all have a great day.
I'm Jake Gallagher. 10-7, dude.
10-7.
2 in.
And 2 out. You've been listening to Hose Jockeys Unite. We hope you've enjoyed this episode, and please tell your friends about us. And always, always remember, even truckies need love too.